So we did cerebrospinal fluid, and we talked about the different parts and how it travels through each component. But let's talk about shunts, or what happens if you choke the chicken. So we said the chicken represents the third ventricle here, right, with the little there, and then the tiny little body was like the fourth ventricle. And then on top, his little hairdo extension thing, right? That's basically the two lateral ventricles. So let's talk about what would happen if I had a blockage in any of these pathways. So if I choke the chicken, right, I grab the neck and I choke the chicken and I cause obstruction in what we call the cerebral aqueduct. What's going to happen to the third ventricle and the two lateral ventricles? Well, it's going to enlarge, right? I still have production of CSF. It's still traveling throughout this system. Even though the CSF pressure and creation of CSF is slow and it's low, over time you're going to have an enlargement, right? And what do we call that? We call that hydrocephaly. So I had a student that had hydrocephaly, and he had these massive migraines. And the migraines, consider this. Why is it that insurance companies will only give a certain portion of, or they'll cover only a certain number of migraine medications throughout the month? It's because if you continue to cover up a problem, like let's say you have migraines and you have severe headaches, and I give you medicine that covers up the pain, do I ever resolve the original problem? No, I don't. So what happens if you don't have access to these pain meds and they're not being covered? Well, you're going to go in to seek medical attention. Now, what happened with one of my students was he said he was an EMT and he used to ride bike everywhere, and then he ended up breaking his arm. And so his arm was, the bone was sticking out, and he went into the hospital to obviously into the emergency room, right? So that they could reassess it and put it back in. And they asked him on a scale of 1 to 10, what was the pain that he was experiencing with the break in the bone? And he told them it's about a 6 or a 7. What do you mean a 6 or 7? Your bone is sticking out of your arm. Well, he said, compared to my headache's about a 9 or a 10. And so they had to reassess his headache and the problems that were occurring with his head. And how did they do that? Well, his physician that was assessing him at the time, he said, was only looking at like very close images between, let's say I take an image today and I take one tomorrow and I compare the one from today to tomorrow. Well, this takes a long time for hydrocephaly to occur, or it can take a long time. So his new physician that was assessing him, his neurologist, took a look at the image from today, right, the time at which he went in for the assessment, and he looked like 10 years back. And so there was a huge difference between what he had seen at the time of the appointment and 10 years prior. So they diagnosed him with hydrocephaly, and they put a shunt. But then in order to remove the fluid that's inside of here and to alleviate the pressure and reduce the symptoms of pain in the head, they put a shunt from the brain and they put it into the peritoneum, which is the abdomen. So they flushed out some of the excess fluid from inside the brain and pushed it into the abdomen, so that you don't want to have it too fast, right? So there's a certain rate at which you do it so that you don't cause any kind of vacuum inside of the brain and other consequences. So they had that shunted out to remove the excess fluid. And what happened? Well, his migraines resolved. He no longer had the headaches. So the reason why you understand this is because if there's any block at any point and you have an enlargement, right? Your patient that has migraines or headaches, you don't want to just keep covering up the medicine. You want to figure out what's wrong. And this is a potential. So instead of looking at now versus yesterday, try and take a timeline back further, maybe. But anyway, point of the whole story is if I have blockage here, I'm going to have hydrocephaly. I want to use the shunt to remove some of the fluid and maybe put another shunt in here so that you remove the blockage, maybe through surgical means, or I don't know if they do laser at this point, but there's the potential for that, right? There we go. The exit point from the subarachnoid space back into the sinuses is through the arachnoid villi, also known as a group as arachnoid granulations. Blood-brain barrier, we've discussed that many, many times. So we can go on to blood supply. I won't test you on blood supply, just understand that there's consequences, right? So if I have blood supply to different parts of the brain, what if I have a clot? So let's take a look at this concept. If I'm in the middle of a river and the river is fast flowing and there is a little stream off to the side, off to the right, off to the left, but I'm smack dab in the middle of this fast flowing river, am I likely to go straight or am I likely to make a cutoff and turn? Well, I'm probably going to go straight. So majority of your clots, including fat, right? So if I have cholesterol, I have fat circulating throughout the blood. Fat is going to end up in a direction that's more straight. So if I have a blood vessel, like in the heart has blood vessels, right? We don't do this until next semester, but here's the concept. So if I have an artery that's straight and a blood vessel, right? The blood vessel is the artery, and I have a clot or I even have a piece of fat molecule moving that way, is it going to go to the right? Is it going to go straight or is it going to go down? It's going to go straight because it's the path of least resistance. So if I have buildup of plaque because of fat buildup, and then I have a clot that subsequently obstructs the area, I'm more likely to obstruct the vessel that's straight. So same thing for the brain. If I have a vessel that's straight, as seen in this diagram, and let's say that there's an internal carotid artery that supplies blood up and inward, am I likely to go straight or am I going to make a U-turn to go off to the side? No, I'm not. So I'm going to have clots that form and lodge here. And that means my deficits in the brain are likely to be in the area of the temporal region, right? This was the temporal from an underside view. And then this is a portion of the frontal brain. So let's cover concepts. If we did this before, that's okay. It's good to repeat. So I love to repeat information. Wernicke's is wordy and Broca's is broken. There's my nose. Okay, Wernicke's wordy, Broca's broken. What does that mean? In the brain, there are speech centers and then there's receptive fields or receptive centers. Well, in the temporal lobe versus the frontal lobe is associated with motor. So there's a speech center around here. It's rough area, and it's called Broca's. So Broca's is your speech center, and then we have something called Wernicke's. Wernicke's is receptive for understanding information. A lot of times you're going to have temporal. Temporal is auditory. So you hear something, you make sense of it, then you communicate your views on whatever topic that is through Broca's area and your speech center. So if I have, like we said, the middle cerebral artery supplies this region of the brain, this entire middle section. If I have an occlusion of that artery because of a clot, and I cannot supply this area and cells start to die off, depending on what side of the brain you're talking about, Wernicke's and Broca's is primarily in the predominant or in the dominant hemisphere. Majority of people have the left side as being the dominant hemisphere. But in general, here's the concept. Broca's is broken. Wernicke's is wordy. That means if I have two patients, and let's classify them as separate. Let's say that it's not global and either one or the other is affected in these two different patients. So the one that's affected by Broca's, that's broken, versus the one that's affected by Wernicke's, that's wordy. If I tell both of them, they're sitting down, and I say, stand up, walk over to the light switch, and turn the light on. The person that has Wernicke's dysfunction is going to say, stand up, walk over to the light switch, and turn the light switch on, or light on. They're going to parrot exactly what you say. So they're wordy. Their comprehension is not there, but their ability to parrot back what you're saying is. So they're going to parrot back what you said. Broca's, on the other hand, they're not able to communicate to you, but they'll stand up, they'll walk over to the light switch, and they'll turn the light switch on. They understand, but they're not able to communicate their understanding to you through speech. Could they take a pen and write down what you said? Likely. If they don't have deficits in the area that allows them to understand and then process the information through writing, then they would be able to do that and communicate to you that way. But for simplicity, we're going to say Broca's is broken, Wernicke's is wordy. Broca's is broken, Wernicke's is wordy. Broca's is broken, Wernicke's is wordy. That's easy for you guys, super easy. So here we go, middle cerebral artery. If it affects the left, the dominant hemisphere, right? And you have Broca's area that's affected, or Wernicke's, then you know Broca's is broken, Wernicke's is wordy. So same thing, just shows you a side profile of middle cerebral artery and what it supplies. This would be an area that's supplied by anterior cerebral artery. That's the center of the frontal lobe. And then posterior cerebral artery would be the posterior aspect leading all the way out to the visual cortex. So what are cerebrovascular accidents? We just went over it, right? We said simply, it's a stroke. What is a stroke? It's the result of some kind of occlusion of a blood vessel to an area or region of the brain. In this case, I have a stroke victim that had a clot that was stuck inside of the middle cerebral artery that affected either one or two of these regions of the brain. So CVAs are also known as strokes. Blood vessels, I'm not too heavy on testing you on that, so don't worry too much. The only thing I might say is superior sagittal sinus versus inferior sagittal sinus. We did review this. And then this guy, because he's straight, we just simply call him the straight sinus. And then from straight sinus, they meet at a conference. They make a conference call. They go across through the transverse sinus. They make an S shape through the sigmoid sinus, and they exit out the internal jugular vein. So again, you guys can look over those. Cerebrovascular disease, stroke was also known as a CVA, or cerebrovascular accident. A blood-brain barrier, more. We love this concept, right? We said blood-brain barrier. What are the cells that help create that barrier? Astrocytes are big ones. So astrocytes help set up this barrier, and I don't care how many times I review this, I love this material, so we're going to cover it again and again and again. Blood-brain barrier, tell-denny, T-L-D-N-E. Tell-denny, tyrosine becomes L-DOPA, L-DOPA becomes dopamine, dopamine becomes norepinephrine, epinephrine becomes norepinephrine becomes epinephrine. These three at the end are what we call catecholamines. This guy in the front, tyrosine, is an amino acid that is converted to L-DOPA. L-DOPA crosses the blood-brain barrier. So let's talk about Parkinson's and review that. The concept is, in Parkinson's, there's deficiency in the release of dopamine from a nucleus called substantia nigra. So substantia nigra is a darkly pigmented, substantially pigmented nucleus that if you were to look at it under image, it would just be a dark staining nucleus. And then it releases dopamine. Dopamine goes through a whole pathway, but dopamine helps to, let's simplify it down to smooth out your movements. So what happens when it's lacking? What kind of movements are you going to see? Dysfunctional, right? Tremors, you might see like a movement that's jerky because dopamine helps to go through the pathway and smooth it out. Tardive dyskinesia is another term that they might use, but I want to replace the dopamine that I lost. How do I do that? Well, I could give dopamine because I don't have dopamine, so I'm going to give dopamine. But the problem with giving dopamine is that the rest of the body will want to consume it as well. We use it for all the receptors throughout the body that are dopamine related. So if I give it, then it doesn't get to the brain, doesn't resolve the problem that we're trying to fix. How do I get there? Well, L-DOPA crosses the blood-brain barrier. And besides, dopamine doesn't cross blood-brain barrier. But L-DOPA does. So if I have L-DOPA, and then L-DOPA crosses the blood-brain barrier, it can be converted. So I'm going to start with L-DOPA. It can then be converted to dopamine by enzymes within the brain so that I replenish the amount of dopamine there. Well, if drugs don't work over time, they're starting to use something that they call deep brain stimulation. It is the coolest thing. I watched it on open brain surgery, and deep brain stimulations, they implant electrodes into your brain in the area of the substantia nigra so that they can stimulate the effects of dopamine through the pathway by using electrical conduction through the pathway. It's just an amazing thing to watch. So the patient that was on the table, he was awake, he was alert, he was answering questions, they had his brain open, they were sticking the electrodes in, and he had this tremor going on. And so my other half was, he had the TV on, I was taking a little nap. As soon as I heard subthalamic nuclei, I woke up. It was like, oh my goodness, this is an amazing thing. So they put the electrodes in, and you could see the tremors when they stimulated it in a manner that effectively went along the pathway. The tremors stopped. And so now you had this person who no longer had the symptoms associated with Parkinson's. Fun tidbits.